Well, good morning, everyone. I'm Dr. Laura Lacher, and welcome to today's Medical Grand Rounds. As usual, we'll go ahead and get started with some reminders, logistics, and then introductions for today's very special talk. Be sure to join us next week. We'll be hosting the Olson Lectureship, and we'll be hosting Dr. Lily Cervantes, who will be giving the talk, Catalyzing Healthcare Policy Change, Community-Partnered Research and Advocacy to Expand Care for Undocumented Immigrants. Just a reminder that Grand Rounds is now a collaboration between Providence St. Vincent and Providence Portland Medical Centers. We often meet here live on Tuesday mornings at 8 a.m. at St. Vincent's and sometimes live at noon, also on Tuesdays at Providence Portland. You can always join us through the virtual Teams Live platform, and you can earn CME credit by being here in the room, by watching live virtual, or by watching a recording of the event. If you check each week's Grand Rounds invite, you'll be able to see exactly when and where we meet, and you'll also be able to find the recording for the session. I'll be monitoring the Q&A throughout today's session, so for those of you joining us online, please feel free to post any comments or any questions, and I'll mostly hold those until the end as time permits. And now to introduce today's very special annual Rosenfeld Lectureship, which was established through an endowment of the children of Mr. and Mrs. Rosenfeld in honor of their parents' 50th wedding anniversary. Their father, Vic, who lived for many years with diabetes, served on St. Vincent's advisory board, as well as the Council of Trustees of the Medical Foundation. And the purpose of this lectureship is to assure a tradition of hosting a national expert in some aspect of the pathophysiology, prevention, or treatment of diabetes. And today we are joined by Dr. Rosalina McCoy, Associate Professor and Vice Chief of Clinical Research in the Division of Endocrinology, Diabetes, and Nutrition, as well as Director of Precision Medicine and Population Health at the University of Maryland. Dr. McCoy is a practicing endocrinologist, a clinician educator, and a physician scientist. She's particularly interested in addressing the multi-level factors that lead to suboptimal care, with the goal of developing precision medicine tools and patient-centered care delivery models that improve health while supporting the sustainability of our healthcare system. Dr. McCoy's methodologic expertise is in the use of real-world data, including administrative claims and electronic health record data, for causal inference, health economics and outcomes, and pharmacoepidemiologic and population health research. She has published over 300 peer-reviewed articles and has contributed to the development and dissemination of clinical guidelines and consensus statements on the management of diabetes, cardiovascular disease, and chronic kidney disease for the American Diabetes Association and the American Heart Association. It is a joy and an honor to have you with us today, Dr. McCoy. Thank you.
Thank you so much. I got all over this. Yeah, thank you so much for your very kind introduction and all of you for being here really early in the morning and really welcoming me to Portland. It's my first time here and it's truly wonderful. I am excited to talk today about really the classification of type 1 and type 2 diabetes, hopefully breaking some misconceptions about kind of who can develop type 1, type 2, and introduce a bit of a provocative thought that I hope you leave with today, and that is that a person can have both, and we can treat both. Hopefully we're a small group here in the audience today, so please, I'd love for this to be interactive as well. I don't get rattled. Ask questions anytime. And let me know if you can't hear me. So I have no disclosures, but very grateful for funding from anyone who is willing to give me money. So what I hope to talk about today is really three things. So one, we'll kind of start with a foundation of the pathophysiologic differences between type 1 and type 2 diabetes and thinking about them as a continuum of progressive dysglycemia for both. We'll talk about how to differentiate between type 1 and type 2 diabetes. And most importantly, what do we do if we're just not sure? And then end, because I'm a firm believer in prevention being critically important. Bit of a detour, but talking about strategies to prevent or delay the onset of both type 1 and type 2 diabetes. So we'll start with this made-up case, which is still very similar to a patient that I took care of recently. So it was a 45-year-old woman who initially was found to have prediabetes 2 years ago, had inconsistent access to care, came in to the office now with an A1C of 8.5. Her BMI was 28, really no family history of diabetes, no prior DKA, kind of really progressive, increase in A1C that we see often. Started on metformin and empagliflozin for combination therapy, and things were well. 6 months later, she presented to the ED with diabetic ketoacidosis. She had a GI illness, had some nausea and vomiting, started feeling rapidly worse, and came to the ED. So while she was being treated for DKA with insulin drip, her A1C was found to be 12.5. She was stabilized, started on insulin, and sent home on metformin, empagliflozin, and basal insulin after her DKA. And when seeing her in follow-up, she said, well, they didn't know what I had. Do I have type 1 diabetes? Do I have type 2 diabetes? Why did I develop DKA? What should I do? So that's kind of the framework for what we're going to do, because these are patients that, at least on our endocrine consult service, we see often. People who were type 2, came in with DKA, we send them out on insulin, and then they ask, do I need this for the rest of my life, right? So and that's why I think it's important to figure out, what does our patient have, right? If we assume that somebody has type 2 diabetes and they really have type 1 and they're not treated with insulin, there's a risk of DKA, which can be fatal. As in this patient, they can get an SGLT2 inhibitor, otherwise a highly beneficial recommended therapy for cardiovascular and kidney risk reduction. But in those with type 1 diabetes, it carries extra risk, particularly for euglycemic DKA. If they are thought to have type 2 and they get a sulfonylurea, which is common, that can accelerate beta cell function and lead to earlier dependency on insulin. They can have prolonged hyperglycemia because they're suboptimally managed, leading to complications. We focus our education on the wrong things. And as we'll talk about at the very end of the talk, there's a missed opportunity for screening of family members and prevention of type 1 diabetes. But if we have this patient who had DKA, we call them type 1, when really they actually had type 2, that leads to unnecessary treatment burden, use of insulin, risk of hypoglycemia and weight gain, and also missed opportunities to prevent the cardiovascular and kidney complication of type 2 diabetes with kind of the CKM targeted therapies. We can also miss treating obesity, right? So I think it's important to know, what does our patient have? And one thing to note is that about 40% of adult onset type 1 diabetes are misdiagnosed. Right? So that's 4 out of 10 people who have type 1 diabetes who are treated as type 2 and then experience these adverse consequences. So what are the differences? So this kind of back to the basics first before I shatter all the myths. So type 1 diabetes, right? It's about 5 to 10% of all cases of diabetes. It is caused by typically autoimmune beta cell destruction, leading to absolute insulin deficiency. There's a strong genetic component and clustering with other autoimmune conditions. The key feature is there is no insulin, hence we treat only with insulin. Type 2 diabetes is the vast majority, 90 to 95%, caused primarily by insulin resistance, ultimately and gradually leading to beta cell failure over time, though initially there's too much insulin, which actually causes a cycle of greater inflammation, greater insulin resistance, so kind of feeding that loop. It too has strong genetic, metabolic, and environmental components, just like type 1. And then we have kind of other specific types that I won't talk a lot about today, but just something to consider when the picture isn't right. So monogenic diabetes, or MODY, really think about that if people are diagnosed, really they don't fit the typical picture of either type 1 or type 2, and there's strong family history of diabetes with that autosomal dominant pattern. Pancreatogenic diabetes that can develop after chronic pancreatitis or pancreatectomy, drug-induced whether it's most often with steroids, post-transplant, and chemotherapy associated. And we'll talk a little bit about chemotherapy associated later today. So always want to consider it if atypical features are present. And there's actually a lot of exciting research going on about MODY and thinking of MODY really as a continuum in that type 1, type 2 space as well. So I think in the next few years, we'll see a lot more understanding of MODY. But I think the clinical reality is that this classification, while useful, it's imperfect because establishing the presence of autoimmunity is not that simple. And insulin deficiency takes time to develop in all cases of diabetes. So it may not, that kind of simple dichotomy may not always tell us what to do, and they can coexist. So let's think about kind of what does that progressive dysglycemia look like in both type 1 and type 2, and how does that help us figure out what our patient might have? So we're used to thinking about progressive dysglycemia in type 2 diabetes. People have metabolic susceptibility to insulin resistance with obesity, sedentary lifestyle, right, family history and genetics. So they develop insulin resistance. And this part is important because many of the complications of diabetes begin to develop at that stage. And that's why at the time of diagnosis of type 2 diabetes, that's why we start screening for everything right away, as opposed to in type 1, where we usually wait 5 years. That's because the complications, cardio-kidney metabolic complications, really develop at this stage. Once insulin resistance progresses, dysglycemia progresses, people have prediabetes, right, with kind of elevations in A1C, fasting plasma glucose, impaired glucose tolerance, but beta cells are still compensating. They're cranking out that insulin. If we were to measure insulin levels, they would be high. Progression continues, and we get overt type 2 diabetes when beta cell compensation fails. And at that time, about a quarter of people already have complications. So mechanistically, it's really a combination of insulin resistance, beta cell failure, incretin deficiency, so inadequate signaling of the GLP-1 and GIP receptors, which should strike a bell, right? Because that's what we target with the Ozempic family that everyone has heard about. And that's incretin deficiency is really what drives postprandial hyperglycemia as opposed to baseline hyperglycemia. And then we have really maldistribution of lipids, which cause insulin resistance as well, particularly at the level of the liver. So it's not just general obesity, but particularly the maldistribution of obesity. That is not where it should be. So that's the pathway of type 2 diabetes. So increasingly, the paradigm of type 1 diabetes has shifted as well to recognize that there are stages and progression of type 1 diabetes as well. It's not a nothing to everything kind of dichotomy. It begins with stage 1 diabetes. So the nomenclature still isn't prediabetes. Prediabetes still refers to pre-type 2 diabetes, though I think that might change. With stage 1, type 1 diabetes, individuals are at risk, but asymptomatic, kind of like that metabolic dysfunction component of type 2 diabetes. Individuals have normal glucose levels, but they already have 2 or more, typically, islet autoantibodies, so the antibodies that will lead to the destruction of beta cells and insulin deficiency over time. About 70% of individuals with stage 1 type 1 will progress to stage 3, which is clinical type 1 diabetes, within 10 years. So it takes a long time. And this is an opportunity for lifestyle optimization, enrollment in clinical trials. There is data that obesity with that increased really burden on beta cells makes it more likely to progress to clinical type 1 and makes it happen faster. So that it's important to identify individuals at this stage for prevention. Then, as autoantibodies do their thing, people develop stage 2 type 1. This is still preclinical type 1, but glucose levels are at the prediabetes kind of range. The number of autoantibodies may decrease at this time, but typically we still see some present. At this point, It's about 2 years to progress to clinical type 1 in almost every patient. And it's an opportunity for teplizumab therapy, which is the only FDA-approved medication to delay the onset of type 1. And we'll talk about that in the end in the prevention part of the talk. Then, over time, people progress to stage 3 type 1 or clinical type 1 diabetes. At this point, they meet diabetes glucose criteria, significant beta cell mass has already been lost, they need insulin, otherwise they develop DKA. Autoantibodies are typically present, but they might actually be absent. And that's important to consider when we start screening people who already have diabetes, they may not have autoantibodies. But stages 1 and 2 are now actionable, which is why it's important to think about them. And I think for those of us in internal medicine, to really counsel patients and their families to consider getting screened. And we'll talk about how they can do that for free at the end. So how do you differentiate between them? And what do we do if it's not clear? So this ABC approach is what's recommended by the American Diabetes Association and really how we were trained, right? We think about age, autoimmunity, body habitus, background or family history, glycemic control, whether they're able to achieve glycemic control on non-type 1 therapies, and key comorbidities, whether they were treated with immune checkpoint inhibitors for cancer, that we'll talk about shortly, that can cause rapid onset of autoimmunity with type 1 diabetes in particular, or vice versa. If they're treated with steroids, they're more likely to have a type 2 type picture. But the challenge is that this is not perfect, right? These are not diagnostic criteria. They lower the threshold to test for type 1. So they should make us think about type 1, but they don't rule it in or rule it out. Because half of type 1 diagnoses occur after age 30. And the mean BMI in US adults with type 1 is almost 28. So it's the same as the general population. So lean body habitus it makes type 2 diabetes less likely, but presence of overweight or obesity does not really make type 1 less likely. Age, I think is, and I'll show you shortly, not very helpful unless they're very young. So I think the background control and comorbidities are very helpful. The first 3 are not. So I think the key is that both and now unfortunately with an increase of obesity, type 2 diabetes develops in adult children and adolescents and in young adults. So both types of diabetes develop at any age in different body types, especially as we are an increasingly diverse population and insulin resistance manifests itself differently in people with different ethnic backgrounds. So people develop type 2 diabetes in different body types and BMI levels. Both can present slowly or quickly. The only thing that is different is the treatment. And we can have both. So these are population-level data from Sweden, where they do really systematic, incredible data and population-level screening. And they looked at let's see if I can help. This works. Oh, yes. Okay. So the age of type 1 diabetes diagnosis, and you see this U-shaped curve for both men and women. And they established the presence of type 1 with antibodies or negative C-peptide, meaning they're not making any endogenous insulin. So they, by definition, have type 1 diabetes. So for the patients that we take care of in internal medicine, I mean, that's a lot of people who develop type 1 at this age. And this is data on the presence on the BMI levels of individuals with no diabetes, with type 1 diabetes and type 2 diabetes from NHANES in the US, sorry, not from NHIS in the US. And you can see that while the BMI, so the presence of overweight, so BMI 25 to 30 or obesity, which is 30 and higher, these are different. Oh my gosh, the crude prevalence in A, I'm struggling with my mouse here, in A, and the adjusted prevalence in B, we basically see that while the prevalence of obesity is lower, obviously, in type 1 compared to type 2. It's very similar to, it's still very common, right? 28% have obesity, 34% are overweight, similar to the general population. So it's not everybody with type 1 is diagnosed when they're lean. So the hallmark of type 1 diabetes is insulin deficiency and usually autoimmunity, depending on when you check. So let's start with how do we approach screening? So the first thing we do is we check for autoantibodies. There are 4 antibodies that you can generally test for. The most common in the first line to be tested is GATA or GAD65. It's the most sensitive, right? It's positive in 85 to 90% of patients who have type 1 diabetes, but it's also the least specific because up to 10% of those with type 2 diabetes will have a low positive GAD65, but they never progress to insulin requirements. So the level, that's the only antibody where you do want to check for the levels because low level and high level GAD65 are different. The next 2 are the ones that, so typically I do a panel of GAD65, IA2A, and the zinc autoantibodies. IA2A and zinc are highly specific for type 1. IA2A is positive in about 60% of new onset type 1, and any positivity is highly predictive of type 1. Similar for the zinc antibodies. The anti-insulin antibodies, they are positive, especially in kids, but the challenge is that for at least us in internal medicine, most patients that we see had already gotten some insulin, so they're going to be positive. So you don't need check it if somebody has received any insulin whatsoever, even if it's a little bit, even if it's correction scale. So very, very rarely check this. Now, so I typically, most people, you either get a GAD65 first. If it's negative, you kind of go by the picture. If it's positive, most of the time I find that you're still getting the panel, so it may just be helpful to get the panel in the first place. Now, know where your labs are done. So Mayo Clinic labs and Enable Biosciences, they have the highest accuracy for all of these. Quest and LabCorp are lower accuracy. So if the results don't jive with a clinical picture, you may consider confirmatory testing. You can do confirmatory testing with the same lab. You just want to check it again in case the results don't align with what you're thinking. So how do you interpret them? So if you have low-level GAD alone, again, remember that can be seen in like 1 out of 10 people with type 2. So you do want to do a confirmatory assay, check the other antibodies in the panel, and check a C-peptide. If someone has low-level GAD and a preserved C-peptide, they're just like any other person with type 2 diabetes. It does not appear that it predicts time to insulin dependency or anything else. You can just ignore it. If it's a high-level GAD65, it's much more likely to be type 1, but a slowly progressive type 1, which we also call LADA. Again, you want to order a C-peptide and consider doing the full panel to tell you whether it's going to be LADA or a more typical type 1 picture. Either IA2 or zinc antibodies are positive, that's going to be type 1. And you can basically rest assured and start the treatment pathway for type 1 diabetes. The more antibodies positive, the more likely it is to be type 1 and the faster the progression to insulin dependency. But about 5 to 10% of people with type 1 are seronegative, either because they're kind of burned out their antibodies at this point when you're testing them, or they have some antibodies that we haven't discovered yet. So antibodies are helpful, but ultimately it's the insulin deficiency. So you use C-peptide and your clinical context. So that's why step 2 is checking a C-peptide. And it's really the beta cell function test. Right, so it's C-peptide is co-secreted with endogenous insulin. It's not affected by exogenous insulin. So if somebody gets insulin injections, that's not going to impact their C-peptide level. The key is not to check it within 2 weeks of severe hyperglycemia, whether it's DKA, HHS, or just really severe hyperglycemia because the toxicity of high glucose levels stuns the pancreas and suppresses your C-peptide. One thing is please do not order insulin levels. We see that a lot in referrals. It's not helpful either direction. It's really completely uninterpretable in insulin-treated patients. In non-insulin treated patients, it's also pretty uninterpretable. The best test is a stimulated or meal C-peptide. It's a little bit deceiving. You want to test their C-peptide when their glucose levels is kind of in the low 100s, ideally. What this means is that you don't want patients who don't have diabetes to fast too long and have low glucose levels, kind of in the 60s, 70s, or 80s, because then you shouldn't be making insulin. The C-peptide is going to be low. So you just want the person not to be malnourished and to have eaten like a decent meal the night before. So that's the gold standard. The fasting C-peptide level as a lab test LOINC code is what Medicare requires for insulin pumps. So you'll still order that. Just make sure it's not like completely long-term fasting, because then clinically it's not interpretable. So just when it's clinical and drug coverage, things go awry. So once you get your C-peptide, if their level is less than 0.2 millimoles per liter, or I don't know what units you guys use, that means there's no insulin production. So that's consistent with type 1 diabetes. You manage them as type 1 diabetes with insulin. If it's more than 0.6, you exclude them having type 1 diabetes right now. But that's why you needed to have antibodies to know what's going to happen in the future. Because it could still be kind of slow onset type 1 or LADA. And you'll need to monitor their C-peptide levels at least annually. Though how often to monitor depends on how many antibodies they have that were positive and what those antibodies were. For those with 2 antibodies that were positive, you'll be monitoring them more frequently. And if they are indeterminate, you use antibodies to help you, and you repeat every 6 to 12 months and just watch for decline. So for me, the approach is you characterize the autoantibodies first, see what they are and what the level is. Then you check your C-peptide to tell you what do you do right now. You do want to contextualize clinically to see kind of how if they had DKA, do they require insulin? What happens if you don't give them insulin? Do they develop DKA? And just in case you want to avoid things that will push them toward insulin requirements, like sulfonylureas, and consider avoiding SGLT2s unless the benefit outweighs the risks. And then you monitor over time. So I think the biggest takeaway is that autoimmunity is dynamic. So a single result is never final. And the picture of type 1 and type 2 evolves over time. Now, sometimes you have all of this data and you're like, oh my gosh, what do you do? Put it together. And that's where LADA comes in. There was a bit of a debate within the ADA of do we even call it LADA or not? I think the goal is really to call it type 1 diabetes with slow onset of insulin dependency, because what we don't want to have happen is people don't think about it being type 1 when somebody is admitted with hyperglycemia that they can develop DKA. We want insulin and technology to be covered by insurance, because really it is type 1 diabetes. It's insulin deficiency, just developed more slowly. So I typically still call patients with a lot of type 1 diabetes to make sure, again, that my biggest fear is they get admitted to the hospital, their blood sugars are normal, their NPO, and they get no insulin. And then DKA develops, which is not ideal. So it's really depending on the data, it's about 2 to 12% of all cases of diabetes. And about 10% of people who are diagnosed as type 2 diabetes have LADA. When I see patients who've had diabetes for a long time and they tell me, oh, well, pills never worked for me, they have LADA. Checking antibodies at that level really won't be helpful, because if they've had diabetes for a long time, they'll burn them out. They're most likely going to be negative. So typically I make it as a clinical diagnosis, because you don't want to add confusion to the situation. their rate of beta cell loss is highly variable. Again, it can take months to years to happen. Often it is a single autoantibody. Typically, it is high level of GAD65, but it can be anything. And patients vary widely for antibody titers, BMI, rates of progression. It's really that gray zone, which is very common. So what do we do in these situations? So do not use type sulfonylureas. They accelerate beta cell exhaustion, they worsen destruction, and have a higher risk of DKA. So that's kind of a big no-no. SGLT2s, again, if there's a stress like an illness, patients are at high risk for developing DKA. They don't have any background insulin. So usually use with caution. If they have high risk chronic kidney disease and heart failure and you want to use an SGLT2, make sure that they have a way to check ketones and they know the symptoms because they often can get euglycemic DKA. So their blood sugars will actually be kind of, high 100s, not what we think about in DKA, but they're going to feel awful. So just education is key. I don't avoid SGLT2s entirely, just make sure it's coupled with the ability to test and an action plan for what to do. Because again, for those with heart failure, it's a toss-up for kind of risk and benefit. And I think if patients are well informed of what to watch out for, they will do okay. GLP-1 receptor agonists can be very helpful in this situation. They improve glycemia without beta cell stress. They actually can improve beta cell preservation. There's a weight benefit for everything else, plus delaying the progression to beta cell loss. There were also trials for DPP-4 inhibitors, which found DPP-4 inhibitors to preserve beta cell function for longer, but they don't generally help with glucose levels that much. So that's why GLP-1s are more preferred. If they can't get GLP-1s or can't tolerate them, DPP-4s can be helpful as well. And this is the time to educate. So I have my patients learn as much as they can about type 1 diabetes, about technology, get to know our educators so that when they do develop insulin requirement, they'll be ready and they'll know what to do. We also monitor them closely so that if once their glucose level starts to rise, we can transition to insulin without having to develop DKA. Because the goal is to diagnose type 1 without DKA at diagnosis. So your educators are really the key members of the team for patients with LADA or uncertainty. So there's two special cases I wanted to mention because they're also in this kind of gray zone. So one is ketosis-prone type 2. So very common in individuals from African American, Hispanic, and West African descent. They have their beta cell function is highly sensitive to glucose toxicity and stress. So when someone gets sick from anything, right, flu, GI illness, beta cells stop working and they develop DKA and they present with DKA. But with recovery from illness, they're usually in a couple of weeks, their beta cell function returns completely to normal, and they have normal type 2 diabetes. And treating individuals with insulin, again, introduces unnecessary risk of complications and treatment burden. So we don't need to do that, but they really need to be educated that if you are sick, start monitoring ketones and may need to have some backup insulin to manage at home so that you avoid hospitalization. So the way to figure out this situation is antibodies, and once they recover from DKA, C-peptide. Because if they have antibodies, so this is the A is for antibodies and beta is for beta cell function. So if they have positive antibodies, and positive beta cell function, so their C-peptide is elevated, they still may have type 1 diabetes, but in those early stages, or they may have LADA, so you monitor them. If they have positive antibodies and negative beta cell function, so low C-peptide, that's classic type 1. We establish the diagnosis. If they have negative antibodies and positive beta cell function, that's the classic ketosis-prone type 2. You wean insulin, educate, provide tools for sick day management. If they are antibody negative and beta cell negative, they still have type 2 ketosis prone, but it's a poor prognosis for insulin independence. Some patients we can watch closely, others do really well on basal insulin only without needing intensive insulin therapy. But this kind of helps them prevent going into DKA. So again, the key is to, after glucose normalizes, 2 weeks after recovery from their DKA, check their C-peptide to kind of help you figure out what to do. But like in our practice in Baltimore, this is very common. And I think it's helpful to reassure patients that they don't have type 1, but it helps to plan for contingencies. The other presentations that we see often is checkpoint inhibitor-induced type 1 diabetes. So typically, this is with the most common pembrolizumab and nivolumab. Basically, patients present with fulminant rapid onset of DKA, can be less than a day. Their glucose levels are completely normal. They have no antibodies. And then by the evening, they're in severe DKA. Antibodies are often negative at presentation, but they do develop later. So this is where we've been working closely with our oncologists just for them to be aware that because often they think, well, my patients with cancer, they're getting steroids. This is just steroid-induced hyperglycemia. We'll kind of tidy them over with some NPH insulin and they'll be completely fine. And they're not. Patients can get very, very sick. So just something to kind of flag for the hospital or for the oncology practice to know that that this is truly type 1. The other thing is we don't stop the checkpoint inhibitor therapy because by the time that they get type 1, this is irreversible. So stopping the immunotherapy is not going to make a difference. So you might as well treat their cancer. They will have type 1 for lifelong. So for our patient, the immediate kind of actions are you stop the EMPA while you're figuring stuff out. You continue the basal insulin until beta cell function can be confirmed. So you wait 2 weeks, you check the C-peptide. You educate on DKA prevention in the meantime, and you check your C-peptide and antibodies, because that is going to help you figure out, can you wean off the basal insulin, or is this type 1 and you need to add mealtime insulin to best manage. So if antibodies are present and C-peptide is low, this is type 1. So you will add mealtime insulin. You'll recommend continuous glucose monitoring, talk about automated insulin delivery systems to reduce treatment burden, educate on type 1, consider screening the family. So the full package of type 1. If it's high GATA and intermediate C-peptide, you'll continue your basal insulin. You don't need to add mealtime insulin just yet, as long as glucose levels are staying okay. You'll avoid sulfonylureas and SGLT2s, and then monitor C-peptide every 6 months or so, and again, educate, because this is LADA, so going to progress to insulin deficiency. Low GATA and high C-peptide, it's most likely type 2 diabetes. I would wean off the insulin, go to non-insulin therapies, but unless in this patient, there's no profound indication for an SGLT2. It's not like there's advanced heart failure or advanced CKD. So I would not use an SGLT2 in this context. Probably use a GLP-1. And then repeat testing in 12 months to see kind of what is going on at that point. And if antibodies are negative and C-peptides are positive and the patient has rapid recovery of the DKA, most likely either a fluke or ketosis-prone type 2. So educate, wean off insulin, manage as normal. Separate topic from this talk, I don't like sulfonylureas, so I still wouldn't use them, but it's not going to hurt them as much as the other 3 patients on this case. So this is kind of the post-hospital follow-up when you see patients after this episode, my general kind of plan. So as promised, what happens if somebody has both? So when you have type 1 and insulin resistance. So it's a distinct phenotype, and there's a debate on whether you sh if the type 1 diabetes diagnosis supersedes everything else, and that's the only thing you can have. I really believe that these are two separate, oh my gosh, pathophysiologic mechanisms, and a person can get both. They can have insulin deficiency and they can have insulin resistance. And it's important beyond just needing higher doses of insulin to maintain glycemia. It's important because up to 65% of US adults with type 1 diabetes have either overweight or obesity, depending on the population, meaning that they're at risk for insulin resistance that is significant enough to classify as a disease. Between 25 and 40% have that level of significant insulin resistance if you were to do kind of that euglycemic clamp in the lab to prove that they have insulin resistance. We'll talk shortly about kind of a simple clinical measure of insulin resistance. But we know that as the insulin sensitivity goes down, cardiovascular disease risk goes up substantially, as does all-cause mortality. So it's important to know that they have both and treat it. So typically, if we have somebody who has obesity and we want to prove that they have insulin resistance, we would use what's called the HOMA-IR equation. It's an equation that looks at fasting insulin levels, fasting glucose, and basically gives you a number that tells you they have insulin resistance. But if you remember, if somebody's already insulin treated, like in type 1, fasting insulin levels are worthless. So we do not use the HOMA-IR equation. Instead, you use the estimated glucose disposal rate. So it's a validated tool that requires kind of a calculator, a waist to hip ratio that we can measure in the office. Yes, no, do they have hypertension, and their hemoglobin A1C level. So all the things that we do in practice. You plug this in, you get the equation, and if the lower the number, the more insulin resistant they are. And I found this to be helpful to basically prove when someone with type 1 diabetes isn't type 1 diabetes plus obesity, but is type 1 diabetes plus type 2 diabetes as two separate diagnoses to put into the chart and then be able, as we'll talk about in the next slide, to actually treat both diseases. And the goal of going through this rigmarole is to prove to the insurance that they have two diseases, that the patient can actually get the medications that clinically will improve their health outcomes. So these, unfortunately, is not programmed into Epic yet, but is something that you can plug in. Also, if you use Open Evidence, it can calculate it for you once you tell it these values and say calculate the EGDR, it's going to do it and interpret it, and you can just paste it into your note. So when do you suspect this? Basically, when you think there's insulin resistance, just like you would in somebody with type 2 diabetes. If they have elevated BMI or elevated relative fat mass, which we basically get with a height and waist ratio. If they need a lot of insulin, so more than 0.7 units per kilogram per day of total daily insulin, that means they have insulin resistance. If they have other measures of metabolic syndromes, right, hypertension, high triglycerides, low HDL, if there's family history of type 2, if you're treating with optimal insulin and their hemoglobin A1C is still elevated, and if they have acanthosis nigricans or metabolic liver disease, again, all indicators of insulin resistance that is significant enough to cause type 2 diabetes. So I mentioned, and it's just things that I often put into my note to justify the medical necessity of treating their type 2 diabetes in the setting of type 1. But we know that the higher the EGDR, the lower the risk for cardiovascular disease and all-cause mortality. we know that more weight gain on intensive insulin therapy from the DCCT trial, again, increases atherosclerotic disease and mortality. It also predicts the risk of diabetic kidney disease, again, all independent of hemoglobin A1C and of metabolic liver disease. So insulin resistance, separate from glycemia, predicts adverse outcomes. So how do we treat both? So you treat both, right? You optimize insulin, ideally with an automated insulin delivery system, because that reduces how much insulin they get total. Less insulin is less weight gain. So you break the cycle of more insulin, more weight gain, more insulin resistance, more insulin, more weight gain. So you want to break that. And AIDs really reduce the need for insulin because it uh, basically finely controls how much insulin they get, and people don't have to overeat for their insulin. And then you manage the metabolic dysfunction through lifestyle optimization with aerobic and resistance training. So I think we increasingly, I think after the 90s, jazzercise push really recognize it's not aerobic is important for your heart, strength training is important for your metabolic health. So we need both. Not just one. So we want to do at least 150 minutes of aerobic exercise and 2 to 3 days a week of resistance strength training. Eat a Mediterranean or lower carb diet, though not a ketone, not a ketogenic diet, because that increases the risk of DKA. So generally just low processed carb diet. What makes sense? Healthy eating. And then manage cardiovascular risk factors with blood pressure, lipids, and aspirin. Annual screening, so all the things that we do. There's less data on what to do for younger people with type 1 because all of this data for cardiovascular risk reduction is for people who are 40 years and older. If someone is less than 40 and has substantial insulin resistance, I still treat those, including with statins. But it's more of an individualized discussion with your patient that weighs the risks and benefits of therapy when it's that early. And then we treat. So the best evidence is for GLP-1s. So in the ADJUST T1D trial of semaglutide in people with type 1 diabetes, we saw a reduction in A1C, reduction in weight, about 23% reduction in total daily insulin. Half of it was due to weight loss, but the other half was through just glycemic lowering. So it plays kind of both roles. There's less hypoglycemia, which is amazing. The key is that you have to lower the mealtime insulin dose by 15 to 20%. Because again, you improve that insulin sensitivity. But it is currently off-label for type 1, which is why it's helpful to say that they also have type 2, which is what you're treating with a semaglutide. There's now trials of tirzepatide specifically in type 1, but preliminary data suggest similar effects. The DEPICT trials with dapagliflozin, which is an SGLT2 inhibitor, actually found similar benefits for A1C, for weight, so less benefits than semaglutide, but you can use both and it will be additive, right? So it's additional benefit. However, the risk of DKA was much higher, up to 4% of people. So that's why we don't currently use it unless there's other compelling indications like heart failure or chronic kidney disease. In Europe, it is approved for people with type 1 diabetes who have BMI of 27 or higher, but not in the US. Metformin was tested for people with double diabetes and really found not much benefit. So there's really no role for metformin in this context. I think it's something that we've often tried in clinical practice because it's easier to get covered. It's much more affordable. It's pretty benign, but it really doesn't help for the double diabetes. So it's kind of like DPP-4s. And then metabolic surgery can be, again, very helpful. It's a high-risk population to do metabolic surgery, especially shortly after when they're not eating well. So there's a very high risk of DKA immediately after surgery. But for those with very high BMI, it can be incredibly helpful and important. So the standards of care starting 2026 have an explicit recommendation that people with type 1 diabetes and obesity should be treated as any people with obesity, with metabolic surgery, with GLP-1s, because they have both conditions. So very quickly to end, I always go far beyond what I think I should. So preventing. So we all know about preventing type 2 diabetes, right? The Diabetes Prevention Program is our foundation. We get a 58% reduction in type 2 diabetes with lifestyle intervention, 31% with metformin. This is what I always show patients because they ask about medicine to prevent it. I was like, but lifestyle is twice as effective. And I think it's really empowering that this is why it's the foundation. It is most effective for people who are older. The ultimate goal is weight loss of at least 7%. And this is where I think reality kicks in, that it's very difficult to achieve and maintain that degree of weight loss in the real world. So while it's the foundation, we shouldn't stop there if it is not working. But please refer patients to the DPP. It is covered by most insurance plans, and yet we generally refer less than 5% of eligible patients. Even if they don't lose enough weight to prevent diabetes, they will get a lot of benefit for cardiovascular risk reductions, for dementia risk, for mental health. So one big debate is why are GLP-1s not recommended for type 2 diabetes prevention. But I think a lot of it is that in this setting, we're actually using it for obesity management and not prevention of type 2 diabetes alone, because we don't have evidence on prevention of diabetes in the absence of obesity. So that's why there's no explicit recommendations in the guidelines for GLP-1s for diabetes prevention, like there is for metformin. But we know from trials of liraglutide, semaglutide, and tirzepatide that the risk of conversion from prediabetes to type 2 diabetes is profoundly less with GLP-1 therapies. So it's an 80% risk reduction with liraglutide. With semaglutide and tirzepatide, it's almost complete reversal of prediabetes with weight loss. So I think the key is to integrate obesity management into type 2 diabetes prevention, those with and without background type 1. So generally, I would use semaglutide or tirzepatide if you're able to get it covered and approved. If they have high risk prediabetes, lower BMI, so less than 30, so you don't get obesity pharmacotherapies, and you can get a GLP-1, then you can do metformin. But really for efficacy and cardiovascular risk reduction, GLP-1s are much more effective. And most payers will cover based on if they cover for obesity, they're much more likely to cover for obesity than for prediabetes, meaning that they might cover obesity and they will not cover for prediabetes. And then type 1, so the key is to screen, because you have to know when to, you need to intervene to prevent before somebody develops type 1. So the current recommendation is to screen first-degree relatives through TrialNet or ASK. There are clinical trial programs that offer free screening. And the patients can go online and kind of get connected. Second and third degree relatives are screened for now as part of research through TrialNet only. General population screening is through T1D Detect. Again, patients, if you give them the resources, it's mostly through research right now. That's the way to get it covered. The key is if they have stage 1 type 1 diabetes, you're just going to be monitoring them every 6 months to detect progression to stage 2 type 1 diabetes. Once they have stage 2 type 1 diabetes, they'll want to be seen in a center that specializes in this because that's when they can get teplizumab to prevent progression. So I think in primary care, the key is to educate about the option of screening and refer to a place that can counsel them and can help them make it happen. But the goal is to prevent DKA. It is not to medicalize before they need therapy. It's really about prevention. So I'll end with this about teplizumab. So it's the very first FDA-approved treatment to delay really type 1 diabetes. It delayed onset to insulin requirement by a median of 2 years. So in the clinical trial, 7% of those in the teplizumab arm or TZIELD developed type 1 compared to 44% in the placebo, so 59% risk reduction. It's now approved, again, for those with stage 2 type 1 diabetes, and clinical trials are ongoing for early stage 3, kind of that honeymoon period. So I think that data is going to come very soon. So I think for all of our patients, think about type 1 for all atypical presentations, irrespective of age and BMI. Check antibodies and C-peptide to help guide therapy. For those who have type 1 and you suspect concurrent type 2, calculate the EGDR and consider GLP-1 therapy to reduce cardiovascular risk. Refer patients to the diabetes prevention program. And for relatives of people with type 1, consider referral to TrialNet and ask for screening and to help them get an early start on prevention or management when the time comes. So I'm sorry for not leaving a ton of time for questions, but hopefully we have a little bit. But this is my email to email me.
Thank you, Dr. McCoy, for a wealth of information. Questions in the room? Thank you.
This was amazing. Would you screen just once for type 1 in a first-degree relative, or would you screen yearly? What are you guys recommending?
That's a really, really good question. We don't know fully what to do. TrialNet and Ask, they're testing different frequencies. Typically for now, we screen once, but if there's multiple, because again, autoimmunity is a process. So if it is high risk, you would screen more. We just don't know how often. Often you do it like when you first figure it out, and then in like 3 or 5 years again. The other part to remember is that most people who develop type 1 do not have a first-degree family member. So that's why there's interest in universal screening, and some countries in Europe are starting to do it. But those are smaller, so it's much more kind of feasible for implementation. And the other part is that almost all the evidence on autoimmunity comes from Caucasian European ancestry populations. So I think there's a lot of caveats. So that's why I think referral to TrialNet and Ask is so important, because they're building the evidence to help us know what to do. But generally, you would screen more than once. We just don't know when.
Quick logistical question from the online audience. Could you please clarify one more time the difference between the stimulated C-peptide test and then the fasting that you need for the Medicare coverage?
Yeah. So when you order it in Epic, just order a fasting C-peptide. That's what comes up, not like the mealtime or stimulated C-peptide. When you talk to your patient, tell them that our goal is for your blood sugar to be in the low 100s. So depending on, you'll know at the time you're seeing your patient what their fasting glucose level is. If their fasting glucose level is already in the low 100s, you're fine with kind of what you order. They do their test in the morning, you get concurrently a C-peptide and a glucose, so you make sure that's interpretable. If the person doesn't have diabetes or pre-diabetes, their fasting glucose level is going to be low, right? So that's kind of where it's important. So they don't have diabetes yet, and their fasting blood sugar, when you've checked it before, let's say is 80. That will not make the C-peptide interpretable. So you'll have them they'll have a glucose meter at home, and I would experiment and see like if they eat something and check like 2 hours later to make sure their blood sugar is in that low 100s, and then you'll know what to do. So clinically, that's the goal. You just want their blood sugar to be in the low 100s. Yeah.
Thank you. That puts us at our 9 o'clock time. Thank you so much, Dr. McCoy.
Thank you.